Good evening, viewers, and welcome to your favorite medical show, Ask Dr. Saw. Tonight, as usual, we are coming to you from TBN Studios and on my page, Akash Prasad. Joining us also is Dr. Saw, who is all the way out in England. He should be back with us sometime soon, but for now, he's there. Dr. Saw, good evening and welcome to the show.
Hi, thank you, Akash. Thanks again for having me.
Brilliant.
And good night to the viewers.
Great. We can't wait to have you back in studio, Doc.
Yes, likewise. I mean, I'm looking forward to that.
Okay, great. So, Doc, tonight we're talking about acne, and we have quite a few questions from last week also, which I'm going to be asking you. We're going to try to fit all into one segment this evening. But
Sure.
Before I get into the questions tonight about the topic, I just wanna say to the viewers, thank you so much for joining us. Thank you for for participating in this show with us. Thank you for your questions, and continue to send in your questions. We are going to be answering your questions on the following week. So whatever question you send in tonight, we are going to be answering those questions for you next week on the show. And remember, the show doesn't have to be about acne, as we are speaking about acne tonight. It can be about any subject, and Dr. Saw will do his best to answer that question for you next week. So this evening we're talking about acne, and we know what acne is, but is there a acne, the moment you see some people getting pimples and so on, we say that is acne. But is there a definition for acne, and can other things show up on our faces that we may think it is acne?
Oh, definitely, of course. I mean, well, medically, we always define a disease or a condition.
Yes.
So yes, there is a definition. So acne is actually, by definition, is a blockage and or an inflammation of the pilosebaceous unit of the skin. So I'll explain that.
Pilosebaceous, talk about one more.
So the pilosebaceous unit includes the hair follicle and the sebaceous gland. So I would ask if you can put up the photo of the skin, and I will go through that, so you will have the viewers will have an idea what's the
photo of the skin. Yes, it's up there, Doc. It's up, yeah.
Okay, fine. So you see the hair follicle, and you've seen a little gland. It's called a sebaceous gland. So the sebaceous gland produces sebum, and sebum is an oily substance that protects the skin. It also, of course, has got antibacterial properties and all of that.
Okay.
So if there is a blockage of that free flow of sebum and inflammation, or you can just have blockage, it is defined as acne. So that's where you have now the acne forms a boil, so we call it comedonal acne. So I have different presentation. I'll tell you about that in a minute. But that's the definition. So that pilosebaceous unit is your hair follicle, where you have the sebaceous gland, and it protects the skin and gives moisture to the skin, and it acts as a barrier to the skin. So when there is inflammation of that, there's a combination of factors. Yeah.
Oh wow. So what causes it then? Are certain people more prone to it? Because a lot of times you'd find that sometimes in an entire family, one person got this thing so bad.
Yes. Now, there are many factors involved. So when we look at it, and that is why when we are managing acne, we have to look at the cause, as in the pathophysiology, we call it, which is like, what are the causes in terms of what disturbance is happening in that gland and that unit. So that pilosebaceous unit, we call it, right? So, okay, there are a couple of theories that we know. We know that there's an increased sebum production. So that oily substance, there's an increased production of that. We know that the outer layer of the skin is called keratin, is a proteinaceous substance, and that blocks the pores. So you're meant to have the flow of the sebum out in the skin, but then you have keratin, that outer layer of the skin, it blocks. So you have an abnormal production or abnormal keratinization of the skin, hyperkeratinization of the skin, so it blocks the pores. And then you have inflammation in the background. And then you have infection. So there are some bacteria that are implicated. So you have something called Cuticobacterium acnes or Propionibacterium acnes. So these are bacteria, microorganism. And then, of course, as you said, in families, you can have it. So you have a genetic predisposition. So if I were to summarize, your question is, what causes it? It's a multifactorial cause. So it's not just one cause. And if I just say, okay, let's look, I like to number things for people to remember. We can say, okay, let us look at the 5 components of it. You have increased sebum production. You have a blockage of the pores. You have inflammation. You have an infective agent. So that's a bacteria. And then you have a genetic predisposition. It runs in family.
Right.
If you get a combination of that, that is what actually is a pathogenesis, or the whole, the medical processes that are, happening that cause inflammation and infection and of the gland.
Wow. But besides the physical thing there, the pimple. I mean, the pimple is there and it presents, that's a physical presentation. Are there other signs of acne? Are there other signs that we can, or is just the pimples?
No, I mean, of course. I mean, we know you have pimples, but people describe pimples differently. You have what is called blackhead.
Right.
And whitehead. So whitehead, you have that little boil with a little pussy bit. You can say that is your whitehead. Your blackhead is that pores where you have oxidation of that, and you get a color change. So you have a black bit at the point there. So that's your comedonal acne, right? Comedones, they call it. And then you have, it can then form a little, we call it a papule, like a raised area on your face.
Right.
So that's your typical description of a boil. So you have these pinpoint things, which is your comedonal type of acne, and then it gets a little bit more inflamed, and you get like a little bump. We call a papule, and then those papule becomes infected where they have white pussy bit. This is called pustules, and then it can form, even get bigger. And then you have a nodule. So that little bump now, a little bump on your face. So, and then of course it can get even bigger and become like a big cyst on your face.
Yes.
So acne, the signs can vary from, you have small little pinpoint comedonal type of acne, and it progresses to a big cyst on your face. And of course multiple cysts, we call it nodular cystic type of acne. That's your severe forms of acne. Now, other signs you could get. So patients would come in, not when they have the first pimple or the first boil on their face. They will come in when it is chronic, that is long-standing. So what they come in with scars. So you'll have different acne over years. I wouldn't find a patient come in with a first boil on their face. They take it, they accept it, they take it for granted. Because when you look at the epidemiology, the prevalence, they say about 50 million people in America affected by per year with acne. And about 80% of the population at some point or the other in their life, they would have been affected with acne. In adolescence, so it's more common in adolescence. So between the ages of 13 and 16, for instance, acne is more common, but it can occur at any age. And and you have acne in babies as well. You can have acne in babies.
Wow.
You have acne common in adolescence, and then you can have it in adulthood as well. So acne is, the whole spectrum of age groups. Coming back to the signs. So when you see these patients with scouring, you can have, we call it like ice pick lesions. Like if somebody stabbed you in your face.
Right.
Holes in your face.
Yeah.
You would know. You look at somebody with those holes in their face and you say, hey, you know that patient's a patient have had chronic acne. And also you have scarring. Hyperpigmentation, we call it, where there are dark spots. You know, when you have an infection and it heals, you have a bit of a scar. So you have these dark spots in white patients, you would have red spots kind of thing. So you have that various presentation. That's your simple acne. But of course, face is involved, your chest is involved, and your back can be involved. And why are those places involved? They have a more dense pilosebaceous unit. So they have more sebaceous gland in those areas, face, chest, back. So you have clusters of those gland and hair follicles.
Okay.
And that is why you will have those areas that are predominantly affected. I mean, there is a severe form of acne. Thank God we hardly, see that. Acne fulminans, where it's like a severe acne where you can have fever. You have lots of nodules and abscess formation. You have fever, you have weakness and malaise and general, you feel very lethargic. And that's a severe form of acne. But we don't normally, hardly we'll see that. Most people, we define acne as mild, moderate, and severe. Mild acne, so I will come to the pictures actually.
You'd like to put it up now? You'd like to put the picture up now?
Yes.
Mild acne.
Mild acne.
Yeah, mild acne.
Let us
It's
look
up.
at
Yeah.
Okay, mild, so viewers, you can see, these are smaller little boils. So we call it comedonal acne. And I'll come, when we look at treatment, we look at mild, moderate, and severe. And then put a severe one. Mild, moderate.
Moderate, yes. Moderate is up, yes.
Moderate. So you see those boils are bigger, more pronounced kind of thing.
Mm-hmm.
And then you have the severe ones.
Right,
If
severe
you look at
there,
that
yes.
Image.
Yes.
Right. So that's your classic presentation of acne. Now, one big part, sorry, I forget this. Presentation in terms of signs and symptoms, psychological component of acne. I mean, this is actually the most significant presentation that I have patients. Young patients, it's common in adolescence. What happened at those age groups? That's the time you're having a boyfriend or a girlfriend, or you're showing an interest in the opposite sex or whatever it is. And then you have, psychological problems. You have patients come in, they have low self-esteem. They say, Doc, I don't look good. I don't, this is really traumatizing me. I don't feel like facing the public. I don't feel like facing people. I think when somebody's looking at me, they're looking at the acne. So they have heightened anxiety and they get depressed. Some patients get lots of patients get depressed with it. They feel, oh, why am I affected? But then if I go on to explain to them, you know what, 90% of people your age group will be affected at some point. Thankfully, the majority of it heals and it doesn't go on for life. And we have lots of treatment we can manage it with. So that's an important aspect, something that,
Yeah. Doc, growing up, I always was told that that acne accompanies you when you become a young man or a young woman. Does it have to do with hormonal changes in the body? Though, why does it present itself during that period?
Absolutely.
Yeah.
Definitely. So yes, indeed, you're spot on there. So the sebum production, so the hormones, as we start getting more hormones, our estrogen or testosterone, it stimulates the sebaceous gland, and it creates more sebum production.
Okay.
And that's the theory where hormonal effects on the pilosebaceous unit, and it causes acne flares up during that period of time. And we see that in even patients who have got, so the patients who are prone, I think you asked me that question, are the people like polycystic ovaries. I don't know if we've spoken about that, but we would have talked about that briefly on other episodes. In polycystic ovaries, these patients, of course, they have irregular periods, they have cysts in the ovaries, they have high level of testosterone. These are girls with either irregular periods or no periods. They have insulin resistance. They can be usually overweight. They have lots of acne. They can have facial hair. But the hallmark, if you do a blood test, you'll find that they have high level of testosterone, male hormones. And that can stimulate the sebaceous gland to produce more secretions. So, yeah.
All right. I'm watching our time. Doc, we got we had about just under 10 minutes to finish up this part of the program before we get into the questions. I want to ask about treatment though. How do you manage acne, because that's a big thing, man. I had an aunt who suffered with acne for years and years. She left her teaching job. She was just a young teacher in high school in Anna Regina. Because of this acne was so bad, and those things that you're going through, all the different stages. It was so bad that she left her job and she stayed home, until she was in her 40s.
So that's it. Exactly. I told you about the psychological impact.
Yes.
Imagine you feel embarrassed to be people looking at you, and you feel that fine. You've got a disease that is contagious or something. So acne can be so severe. In one of the photographs that I've sent there, the one in the severe acne, I mean, it can be scarring for life, generally. It's a difficult one. Okay, but as
treatment.
I say, back in the days, maybe we weren't so aggressive in treatment, and there weren't so many products. And of course, science has evolved now, and we've got a lot more knowledge, and in terms of, research is being done in different areas. So treatment is very, we've got lots we can treat acne with. Now, let us look, so the different types of acne, usually we will treat it more, the severe types more aggressively. So we start with mild acne, or even moderate severe, or sometimes we do a combination of treatment. The treatment ranges from topical treatment. So topical treatment means lotions and cream. That's topical. You just apply lotions and cream. So I'll go through that in a minute. And then so usually I do that. I tell patients, tell me where your acne is. I show them the picture. They say, okay, I've got mild acne. All right, we don't need to be too aggressive. We go with topical treatment. Then moderate acne, topical treatment is not going to be effective. So I would add oral antibiotics. So this is your normal antibiotics that you would use if you have an infection. You have some antibiotics for a week. However, there are special types of antibiotics that we will use for 3 months. I tell patients, if I'm going to give you antibiotics for acne, the minimum time you should be on it 3 months for me to make a judgment. So it is not like you go to the doctor and they give you a week of antibiotics. No, that's not going to cut it. You would have to take antibiotics every day for about 3 months minimum. And then I would review you, and if need be, I'll give you. And then you have, then I'll give you for longer even. I get patients sometimes a whole year on antibiotics, but usually I tend to give them antibiotics for a few months, minimum 3 months, maybe 6 months, take a little break, because usually you'll see results by 3 months. If they need another course, I'll do it 6 months. They usually get better, then we go to the next course. Then we take a break, and then if it comes again, we go to another course. But let's talk about the topical treatment. What are the topical treatment agents? So you heard of retinoids. I don't know if retinoids. We know benzyl peroxide. I don't know what are products like Joac we have. Joac, I don't know. Okay, fine. Probably, I know lots of patients who are affected, they would be prescribed this.
Right.
But we have benzyl peroxide as an agent. How it works, so it comes in a cream form or a lotion, and you apply it on the face. It works as an anti-inflammatory and an antibacterial. Because we say in the pathology, the problem what is wrong is that you have bacteria, you have inflammation, you have blockage and all of that in the pores. Then you have some drugs called retinoids. So retinoids they have topical and oral that you drink, and like tablets, but they're topical. So this is for mild acne. The topical treatment of retinoids, they call it like Retin-A. In Guyana, I know we used to have a cream called Retin-A. So it's called tretinoin cream. So it's a retinoid, or adapalene is another retinoid. So these are creams and lotions, right?
Right.
So you apply them. Some patients, just let the patient know that if you use the cream, sometimes it can cause a bit of redness and inflammation of your skin. So I normally tell them use it in the evening. Also, especially if you go in the sun, it can cause redness. So I would say apply it at night, once a day at night. And then what else do we have? We have some acid-like, so it's called azelaic acid or salicylic acid. They are abrasive agents, and they break down the keratin.
Okay.
And they help to unplug the pores. So all these are topical treatment that you can have: retinoids, benzoyl peroxide, azelaic acid, salicylic acid. They come in creams and lotions, and sometimes you do a mixture of these. And by the way, besides applying those lotions and cream, I would say a normal cleanser for the face. I normally prescribe a moisturizing antibacterial cleanser. So they have, in the UK here, I use dermal wash. So I tell patients to use dermal wash twice a day, and then once a day they use these cream, either once or twice a day, depending on what combination of cream I will give them. Now that's for your mild acne. For your moderate acne now, so I will then review them in 6 weeks, see the response. If acne is getting worse or not getting better, then I can escalate my treatment. So I go to the next stage, and then I give moderate acne now. I will give oral medication. That's your antibiotics. So the classical antibiotics would be the tetracycline family of antibiotics. You've heard of tetracycline?
Yes.
So we have limicycline as one of them, the commonly used one. Limicycline. You have minocycline. So these are a group of antibiotics. If patients can't tolerate those families, there are others like erythromycin and another one called trimethoprim. So these are antibiotics they take every day, and minimum, as I said, 3 months, and then I'll review that. Now, there are a set of patients who have severe scarring, nodular cystic acne. And that's the one that is severe with the big bumps and boils and lumps in it. Now, in those patients, you want to give them oral retinoids. So there's a drug called Roaccutane. Roaccutane or isotretinoin. In Ghana, we know it as Roaccutane. It's a tablet you take. Now, this drug is serious. When I say it's serious, meaning you don't take that lightly and that anybody should just prescribe it.
Okay.
It should be done by somebody who knows what they're prescribing, because there are some precautions you have to take. So before I start patient on the drug, I'll have their blood profile done. Importantly, we want to know their cholesterol level, because the drug side effect can cause your cholesterol to go up. So it's called something called dyslipidemia. Your cholesterol, your triglyceride, and everything just go abnormal. Your liver can be affected, so you can set up your liver enzymes. So the drug is serious. So I will do the liver profile and some blood tests prior to starting the medication.
Okay.
The drug is also teratogenic. That means it can cause malformation if you're pregnant in the child. So you won't take the drug and say, right, you have it. We have a guidance here. You have to take contraceptive, or you can't get pregnant if you're going to be in the drug. So we have a protocol you have to follow. And then every time you come for a review, I have to do a pregnancy test and ensure that you do pregnancy tests before you start the drug. And every month when you come for a review, we'll do pregnancy tests. And then we'll do interval blood tests. The drug also side effects. It can cause psychiatric issues, depression, suicidal tendencies. So you need to counsel the patient about that. If they feel suicidal, depressive, of course, they should report it. It increases sensitivity of the skin as well. So going into the sun, and then I would tell patients not to have, skin peel. Some patients go and have skin peel and abrasive agents. So those are the kind of things I would advise patient. But that's your severe nodular acne. Thankfully, we don't have lots of patients on those drugs. I would say for majority of our patients would be your topical treatment and your oral antibiotics.
All right, great.
And we have lots in the line.
Brilliant. We got less than 10 minutes to go to get this out. Get these two other questions I want to ask you, and some questions from our general public. Remember, viewers, continue sending your questions to us. Now, I got a little thing. I just feeling for it here. I find I get a little one here on my face. I don't usually get these things, but I found that it came over the last 2 weeks. I find like I was I got a little sweet tooth, and I was eating some sweet, using a lot of sugar, and eating some sweet things. Does sweet causes this, or is something else?
All right. So when we say about the cause, we look at cause and effect. So I wouldn't say sweet is a cause, but we have what we call triggers. And there are some studies that have shown that the type of food you eat, we call them low glycemic index or high glycemic index. So if you have a sugary that releases sugar in the blood fast, we call that high glycemic food. And like diabetics, we don't want them to eat high glycemic food. Then you have low glycemic food that releases sugar slowly in your body. So there is some studies that have shown that high glycemic food, that is sugary food, can trigger acne, or it can make your acne worse. And there are lots of theory that it causes the sebaceous secretion and keratinization, abnormality of the keratinization in the gland, in that pilosebaceous unit. So yes, and fizzy drink and sweet things are some reported. There is some association in studies, but we don't have enough evidence to say definitively that this is your cause or this is your trigger. But I would tell patients, if you know you're doing this and you're having a flare, then stay away from it. But yeah, that's the kind of thing.
Yeah, and I find that it happens. I find that it happens sometimes just when you start doing some exercise program or something like that, because of the pores are opening up for you to you'd find that these things coming out in your face on your face sometimes too, right? Yeah.
Definitely. Once the whole mechanism of blockage of your pores and skin and even stress, there are triggers. I've seen patients who just before they get married, they're all anxious and stressed out about things. They can have a flare up of acne.
Brilliant. All right. Are there any horrible or dietary supplement that you can use, treatment that you can use?
I would say horrible. Green tea is a known anti-acne type of thing. There is some Korean medicine, horrible Korean medicine that has been published that they have done some studies on, but we don't have enough robust evidence.
Okay.
So the Dermatologic Society, their consensus guidance would say that they do not have any robust evidence to recommend any particular horrible type of treatment. There's a Korean drug, it's a long name, Cheong Sang Bang Pung.
You sound like Korean there, Doc.
But I mean, there are some studies that show that they use it for acne, but the evidence is very weak. There are lots of anecdotal things, and I don't think in conventional medicine I would say that I can, wholeheartedly recommend particular horrible stuff.
All right, we're going to do this rapid now. We just got about 8 minutes to go. Last question I want to ask you, though. Look, one of the most satisfying things for some people is popping a pimple. Should we or can we pop a pimple?
Should we pop? The answer is no. Can we pop? The answer is yes.
Yeah, right.
Now, okay, meaning that, if you see something that is coming out, it's already out, you touch it, it will go.
Okay.
Then nothing is wrong with doing that.
Right.
The problem is, when it is halfway there and you're not sure, and you see that boil coming out and you start...
Yeah, that's right, yeah.
What you're doing, you're causing more inflammation. What you're doing also, you're poking your finger into it, you're causing scarring. So your fingernails get into your skin, damages the skin. You have a big scar now. Then it may not be ready, where you don't know when it is ready.
Right.
So the point is, the general advice is do not pop a pimple. However, I would say to patients, there are doctors and aesthetic guys who would say, fine, we've seen this is ready, and they have some device where you can pop it. I would say to patient, if there's a pussy stuff, they say once there's pus, let it out.
Right.
That's the ground rule in medicine.
Yeah.
Have an abscess, you want it pus out for it to heal.
Right.
It will heal faster. So if you're seeing that, okay, this thing is already out, if you touch it, it will burst. You can get a warm, wash your face, get some moist tissue or a cloth, and you can use that where it squeezes the side without puncturing the skin or hurting the skin. But there's a danger area in the face. Robbie, can you put up that photograph?
Yeah, the triangle.
There's a danger area in the face. We said do not pop.
Yeah, that's it. Yeah, it's up.
Area.
Yeah, it's up there. Yeah.
Right. So that danger area is the reason being in that area there are lots of blood supply, and there's a blood vessel that connects at the back of the eye to the brain, and it's called the cavernous sinus.
Okay.
So if you have an infection in that area and you keep poking and it gets infected, you can send infection deep into the sinus, into the cavernous sinus, that's the blood vessel, into the brain. You can have blood clots, you can have infection, and that's a danger area. So we tell patients not to do that. And, generally it's not recommended. I think we beat it for time. So
Right. All right, good.
Coming back to diet as well, there's some evidence that diet in polyphenols and flavonoids like berries and fruits and vegetable, they can help. Antioxidant and anti-inflammatory properties they can help acne.
All right, good. So we got these questions here. You got about 60 seconds to answer each one of them as best as possible in the interest of time. I do not drink alcohol, but developed fatty and cirrhosis liver after chemo. How can I repair this?
Okay, so there are two components to that question. Alcohol is not the only cause of fatty liver. So you can have, I think when I spoke about fatty liver, I said there are certain drugs that can cause fatty liver. So did the person say after chemo?
Yes, after chemo, yeah.
Right, so chemotherapy, so there's a drug called fluorouracil that they use sometimes. There are lots of chemotherapy drugs that can cause fatty liver, and it can cause inflammation. It can cause hepatitis even, inflammation of the liver. And so yes, without alcohol, fatty liver can cause from drugs, and also, of course, we know obesity as a cause, and high cholesterol and triglyceride, diabetes are all causes. So the answer to that question, yes. How can you reverse it? Now, if that patient is saying that they have got chemotherapy-induced fatty liver, the fatty liver, of course, we will manage we will tailor, the oncologist or your cancer doctor will say, fine, we may adjust the dosage of your chemotherapy, we may switch your chemotherapy if we know you're having inflammation of the liver. So if you're having hepatitis as a result of a side effect of the drug, of course, I have to reconsider that drug. I'm not going to give you a drug curing your cancer, but I knock your liver out.
Right.
It's not going to happen.
Yeah.
So what we'll do, we will either look at alternatives, we will look at the change in the dosage, or we'll do constant monitoring to see if that is something we can do. Of course, the oncologist or your cancer specialist will make that decision. For the fatty liver itself, I would suppose that you can have a bit of fatty liver with chemotherapy. Your chemotherapy is over, you still have fatty liver, then of course I'll go through the traditional way of treating it, your diet, your exercise, your weight loss program, and diabetic drugs can help that.
Good, great. We got 3 minutes to go, Doc. Can cirrhosis will be reversed? Similar question.
The answer to that is no, cirrhosis is not reversible, but if you start getting fat, because cirrhosis is an end stage.
Yeah.
You get fatty liver, fibrosis, cirrhosis. So fatty liver, inflammation, those can be reversed. But the cirrhosis is like end stage.
Okay, great. Doc, is itchy skin a symptom of fatty liver?
Yes, it can be, and not necessarily fatty liver, but liver disease. So when you have liver disease, your overproduction of bile and buildup of bile in the body can cause itching of your skin as well. So if your liver function is abnormal, and it can cause itching of the skin. So yes, not necessarily fatty liver per se, but liver disease can cause that.
Doc, fluid retention in fatty liver. Is there a cure for that?
There is treatment. Cure would be looking at the cause of the fatty liver. So hold on, let us get this clear. The fatty liver is actually not the cause of fluid retention. It's when you have liver disease, and the liver, I told you that liver produce certain protein to keep the fluid in the blood.
Right.
Whereas if the liver start malfunction, so fatty liver is the beginning of malfunctioning of the liver, then you get hepatitis, inflammation of the liver, cirrhosis. In that spectrum of condition where you have in the liver malfunctioning, you get less production of these protein, you have fluids seeping out of the blood vessels, you have swollen tummy, ascites, and all of that fluid retention we can manage. Of course, there, different ways you can manage it. You can control your salt intake. We can give you some water tablet. There are different types of water tablet. And then last resort, we can put a needle in or a tube in and drain the ascites, drain the fluid out. So there are different ways, but that is when you have that buildup of fluid, it means your liver is really gone, far gone. Okay,
great. Last question here, and we got to get this one out quickly. What are your thoughts on GLP-1?
Okay, GLP-1, I spoke about that, is a drug like Ozempic and Mounjaro, weight loss drug. So I think that's a big topic by itself. I've touched on that in our previous video.
Yes.
I talked about Ozempic. So on that, if viewers can have a look, because we're running out of time, I cannot do that in 1 minute.
Right.
So let us do that as a new topic. I'll talk about obesity and GLP-1.
Brilliant. Great. Thank you so much, Doc. Viewers, thank you so much for joining us tonight. It was an amazing half an hour. We just went over that to deal with the questions. But I'll say continue to send in your questions. Anything in closing, Doc?
No, good night. I know we run out of time, and hopefully I'll see you soon. And to the viewers, good night. Thanks again for having me.
Right. So, viewers, sorry if we seem as if we're pushing for time here, but we're trying to do this in a certain block of time, and we want to get all of this out and get all of the get your questions in also for that time. So, thank you so much for joining us. Remember to stay healthy, stay safe, and remember take care of yourself on our roadways also. All right. Have a wonderful evening, everybody.